Hi, everyone. Welcome to today's Commodore Classrooms, Mental Health and Social Wellbeing during the COVID-19 pandemic. My name is Whitney Sutton, and I am co-president of the Chicago Alumni Chapter, and the Chicago Chapter is very pleased to serve as host for this event. So for today's lecture, please use the Q&A feature to submit any questions you have throughout the presentation. Also, there will be a link to a survey in the chat box near the end, so we would appreciate any input and feedback that you have for future events. Now I'd like to turn the program over to Claire Whitaker to introduce our speaker.
Thank you, Whitney. Hello, everyone. My name is Claire Whitaker, and I am Social Media Chair of the Chicago Chapter. Our speaker and guest for today is Professor Sohee Park. Sohee Park received her BA from the University of Cambridge and PhD from Harvard University. After completing a postdoctoral fellowship at the University Hospital of Zurich in Switzerland, Park returned to the States to build a research laboratory, first at Northwestern University and later at Vanderbilt. Park has held visiting faculty and fellowship positions in Europe and Asia, and she works diligently to maintain collaborative networks across multiple continents. And now I would like to turn over the presentation to Professor Park.
Okay. Well, thank you very much for inviting me, first of all. And I would like to say I'm so grateful that we're here together after living through a year and a half of pandemic. And so let me begin by showing you some pictures of your beloved campus. Let me just start here. Okay, so just forward the, okay. So this is a picture I took about a couple of weeks after the campus closed down in early April. This is Wilson Hall, where I teach, and my office in the top left corner there. As you can see, after this, all the students were sent home after the spring break. We closed down, and then we began the massively complicated process of moving from in-person university to Zoom university. So this is a photo I took in April, and when Wilson became off limits, at this point, we couldn't go back in. And it really sort of hit me to look at the door. Says the area has been disinfected and you couldn't go in. So we had entered rapidly changing new world with no end in sight then. So throughout the year, I would go into campus to walk my dog, and it was empty. Nobody there most of the time. And this is when I sort of realized without students, without people, a university is not university, right? So it's you that makes the college. When the students returned in the fall, these gigantic tents, as you can see on the top, bottom right, they popped up for students to use for dining and studying and so on. But the campus continued to look empty as people really didn't venture out much. So we spent a whole academic year on the siege. However, with vaccination this spring, and basically with a sort of increased control of the pandemic, we were able to have socially distanced graduation in May, which is amazing. So this picture I'll show you from May, where we had graduation. This is Dean Andre Christie Meisel of graduate school giving speech. So here we are in the summer of 2021, slowly emerging from a year and a half of social distancing, social isolation, and anxiety that most of us had never even imagined before. So just to begin, of course, we've always lived with pandemics and epidemics and infectious diseases. In fact, infectious diseases have really accompanied us throughout history. As you can see here, here, if you look at on the right panel, the bubonic plague actually was the biggest killer of all pandemics. So far, it killed up to 60% of all Europeans, right? But since then, there have been smallpox, there was Spanish flu, there's cholera outbreak, and of course, AIDS, HIV epidemic, that's still ongoing, which has killed 35 million people. And even in this century, when you look at from the year 2000, we've had several epidemics. We've had the SARS, the first SARS, swine flu, Ebola, MERS, and so on, actually Zika as well. But those were much more local, and then comes COVID as well, which is still ongoing as well. So if you look at on the right, the death toll as a percent of the population. If you look at COVID-19, it seems less threatening than other epidemics and pandemics before. However, what is really important here is that the speed with which it shut down entire world and paralyzed almost every country, and also the speed with which various mitigation strategies and coping skills and social distancing, as well as vaccine developed. So it's a very rapid turnover. It hit us really badly, but then, for example, vaccine development is amazing, the speed with which it popped up. So here we are in June of 2021. Just want to remind you what we've been through. If you look at the new reported cases by day, and also on the right panel, number of hospitalizations. Back in June of last year, 1,300 people were dying per day of COVID. This year now it's about 300 per day, and it's going down, and 50% or more are vaccinated currently. So there's reason to hope. Okay, so in this talk, what I'm going to focus on is specific, actually a large portion of the general public. So if COVID hit, either you had it or not. So when you go to the right side of the flow chart, if you had it, outcome would be either you recover or one might die. If you recover, the outcome could be really good. You go back to normal, how you were before. But unfortunately, a lot of people suffer from long COVID. So survivors, a lot of them have heart, lung, brain damage, they have inflammation. It's ongoing battle with immune system damage. And other people also have neuropsychiatric symptoms, which may result from these systemic damages. And so there's a group of people who had COVID who are suffering from all kinds of wide range of conditions. If you go to the left side of the screen, most of us did not have COVID. We were very lucky. Oops, I'll go back. Sorry. So some of us had absolutely no change in health outcomes, so that's great, nothing changed. But many of us, there have been changes, and these are mostly mental health challenges. So the rate of depression, anxiety, substance use, psychosis all went up during COVID. So we're going to focus today on the left side, this group here. Okay. So outlines, I'll briefly give you background and introduction to mental health, mental illness, what it is, how costly it is to the person and society. Then I'll go and describe our international mental health surveys. And then the third part, we'll talk about what lessons we learned, and I'll ask you some questions there as well. Sorry, just coming back. Okay, there. So first of all, let's talk about what mental illness is, and then who suffers from mental illness, how it affects society, and then we go and explore the psychological effects of pandemic on the general public. Okay, so here. So what is mental illness? As you know, it's a health condition that involves changes in thinking, emotion, behavior that cause distress and problem functioning in society. And these could be the various categories of illnesses: depression, anxiety, substance abuse, eating disorder, schizophrenia, and so on. So this is according to American Psychiatric Association. These are presented as categorical conditions. However, in reality, it's not like that. These are overlapping conditions. You cannot say where depression ends and anxiety begins, or where schizophrenia begins and bipolar disorder ends. These are kind of enmeshed together. So I just wanted to sort of bring that up to say it's not either or, you can have multiple conditions. Now, the etiological factor is very complex. Both genes and environmental interactions are involved. So on one hand, it's kind of frustrating because it's very hard to figure out what causes these conditions. However, the flip side is that there's lots of room for intervention. There are lots of things you can do to improve the condition. All right, so who has mental illness? These are some of the people you'll recognize. They've all suffered or they still suffer from mental illness. Obviously, these are famous people who achieved much in life despite their conditions. There are obviously billions of other people who suffer in silence. Okay, let me just go to next slide. Okay, now it's very common. Therefore, I just want to emphasize that more than 1 billion people worldwide have mental illness diagnosed. It affects also more than the person who is diagnosed, because it affects their families, their friends, their caregivers, their employers, their students, their professors, everybody. 1/5 of American adults experience some form of mental illness at any given time, and 1/10 from substance use disorder, and these are underestimates. And mental illness is expected to cost the world economy about 6 trillion per year. Sorry, it keeps going back. In terms of poor health and reduced productivity by the year 2030, which is coming up soon. And now, as of now, anxiety and depression, two of the most common mental illnesses, already cost the global economy $1 trillion per year already. So this is a personal problem, but also big societal problem as well. This is what it looks like. You see how many people affected worldwide. 260 million people currently are diagnosed with depressive disorders, but there are lots of people who are on the threshold who are not diagnosed, who are not treatment seeking. I didn't put the substance abuse here, but also substance use, including alcohol, is about up to 200 million people worldwide. So it's a lot of people. Sorry, it keeps going back. Okay, so how do you even measure this? WHO has a system. They've been looking at global burden of disease since 1990. And they have basically most comprehensive worldwide observational epidemiological study going on. They look at the health effects of more than 100 diseases, including psychological disorders. And they quantify the burden of disease, and it's known as disability adjusted life year dailies. When you look at what dailies are, mental and behavioral disorders accounts for the largest percent of global burden of diseases. So it's a huge disease burden here. And it really is loss of lifelong human potential due to this condition. When you look at sort of what these are in terms of different conditions, the highest disability weights are really with psychological disorders. Acute schizophrenia has the highest disability weight of all illnesses, including cancer, spinal cord lesion at neck untreated, and so on. So that's extremely high. Depression is not far behind either on this list. And treated schizophrenia is still up there, and so on. So you can see these are just like top ones, but below that you have anxiety and other things as well. So it's huge. So psychiatric disorders come with very, very high personal, societal, and economic burden that affects patients, families, caregivers, and society. And it has both direct costs and indirect costs, and it's a big percent of the GNP. So direct costs includes like medication, hospital costs, and so on, but indirect costs are the big ones. It's a loss of productivity and accidental damage and so on. All right, but that was all prior to the pandemic when things were without COVID. What happened after pandemic? So this was important for us to look at because it was such a global upheaval of everything that happened before. So we expected it to exacerbate existing mental illness. If you're already diagnosed with something, if you already had risk factors, remember 1/5 already are diagnosed with something in the United States, it will get worse. Secondly, in addition to people already have mental illness, there will be new onset of mental illness. So there'll be triggering factors. So there'll be post-traumatic stress disorder, depression, substance abuse, and so on. And we were concerned that adolescents and young adults would be especially at risk, for example, college students. And these things lead to increased distress of the caregivers of affected individuals, like their families. Now, those people, survivors of COVID, of course, they have direct effects of the virus on the brain. And it might be consequence of delirium, for example, consequence of hypoxia, which both cause brain damage. So they have neuroinflammation, strokes, lesions, and so on. So they do complain of brain fog, cognitive impairment. A lot of people have had depression, anxiety, psychosis, PTSD, and so on. So these are all ongoing. So just going back to how the numbers, currently, as of now, 175 million people worldwide infected. In US, about 33 million infected and 600,000 people have died. And with survivors COVID, we expected there will be severe consequences on their mental health, because we know from catastrophic outcome of SARS survivors in Hong Kong from 2003, almost 60% of SARS survivors eventually got diagnosed with mental illness as well. Early outcome studies of COVID survivors conducted in China show that very high prevalence of post-traumatic stress disorder in COVID survivors, which is not surprising. And then later on the year, studies show that there were neurological symptoms in more than 80% of COVID survivors who had been hospitalized. So these are significant effects. So the survivors of COVID, but what about the general population? We also expected mental illness epidemic in people who didn't have exposure to COVID. Why is that? Because there are a couple of things. First of all, chronically elevated stress, anxiety, and fear due to pandemic-related upheaval, which would interfere with their daily functioning. And also a lot of people that be financial stress as well, loss of jobs and so on. Secondly, there's public health strategies that are designed to curb the spread of the disease. They actually may have had unintended negative psychological effects. For example, lockdowns and quarantine and social distancing protocols, they successfully protect the public from COVID, but they also disrupt your usual accustomed social network as well. Secondly, prolonged social isolation is known to increase stress, panic, depression, anxiety, and importantly, psychosis in even healthy people. Studies of solitary confinement in prisons show that after 24 hours of solitary confinement, most people start having hallucinations. Okay, so social isolation, disconnection, loneliness, the big factor. Now, long before COVID, back in 2017, 2016-17, then US Surgeon General Dr. Murthy, who is US Surgeon General again now, he pointed to loneliness as #1 public health crisis. And he pointed that is a major contributor to poor health in general, but also mental illness, as well as poor school and work performance, and importantly, sense of division and polarization in our society. Social isolation and loneliness has long been shown to be correlated to poor health outcome, perhaps even worse than smoking. And subjective feeling of loneliness may be much more important than actual objective measure of social quantity. Okay, so what we looked at was we did survey studies because we couldn't do any in-person work anymore. So we did online survey studies divided into 3 phases. Phase 1 was early phase from March to June of last year. And from late June to fall, it was phase 2. And phase 3 began later in the year, in the winter. And I'll just show you what we've done with those. Okay, so let's go back to the timeline. The first case was reported in January in China. In February in South Korea, cases began to surge. It's one of the first countries where it really spread, but it was fairly localized. In March, WHO designated pandemic status to COVID-19. And this is when also Vanderbilt closed down, most colleges closed down then. So we began our studies around the same time as WHO pandemic designation, and phase 1 began. And we looked at 4 countries, Hong Kong, South Korea, USA, and France. Okay, and then phase 2 began, and we have slightly different configuration of countries there. Oops, okay. So we looked at general adult population in USA, Korea, Hong Kong, and France. And because they had different public health strategies, different rates of infection, very different cultures, and so on. What's in the survey? We looked at demographics. We measured depression, anxiety, stress, and psychosis. We collected data on their social connectivity, loneliness, and social network. We looked at their general health. And in France, we collected diary entries. So just to remind you how bad things, well, phase 1 here, Well, things got much worse later, but this you're looking at cumulative COVID cases there in early. Okay, so the 4 countries, they're interesting because they're different in their family structure as well. So this is who they were living with and how they're living. This is the darker blues, well, it's sky blue, but darker blue, are people who are married or living with their long-term partners. So majority in all countries, well, in France, Hong Kong, and well, all the countries, yeah, majority of people are living with someone. So the darker blue were married or long-term partners living together. Lighter blue is singles who live with their families. Those actually represent mostly students who went home. So these are young people who are living with their families. And then yellow are singles who are living alone. So we expected the singles living alone would be the loneliest, and they might suffer the consequences much more severely than others because they were just alone. Okay, so the proportion of singles in these samples were interestingly roughly about the same in US, Korea, and France. In Hong Kong, though, most people were living with someone. So singles were living alone was only 9% of the population. The French were mostly married or living with someone, long-term partners, sorry, it keeps going back, and so on. And the proportion of, so these yellow parts about the same across these countries. Proportion married is about 1/3 here, Korea and Hong Kong, much higher in USA and France. And what about the concerns about COVID? How worried were they? Well, if you look at the blue part, those are extreme worriers. They're about this, not that different between USA, Korea, Hong Kong, a little bit more. Most people are moderately worried, for example, Hong Kong, France, USA, Korea, all around the same. French were the least worried, about more than half of them weren't worried that much, whereas the other 3 are about the same. So this is just briefly the demographics, average age in 30s and 40s and so on. Okay, let me just go to next slide. There are differences in these 4 countries because in different ways, of course, different size, the USA being the largest, but they're also very different social distancing public health policies. France had the strictest strategy. They were locked down. To go out to get even medicine and grocery store, they had to get permission, they had to print it out, and they could only go out within certain meters of their household, and so on, very strict. Korea, even though it had early spike of COVID, didn't go into nationwide lockdown. Only the area where there were cases were locked down. It was very localized, and they relied mostly on contact tracing and early testing. Hong Kong did some of that. Again, it's much more localized. USA had a very confusing policies and strategies, and it didn't work by and large. I mean, people compliance was very low in the USA. Third thing is political unrest and political crisis and civil unrest. Korea and France had nothing going on, political, social. Hong Kong, yes, it had been going on since 2017, and it was still ongoing. Lots of arrests and so on. USA, as you remember last year, lots of political, social unrest. Lastly, there's a huge gender gap index differences. This is from World Economic Forum. Number 1 country in terms of gender equity is Iceland. There's almost parity there. The worst country is Yemen at rank 153. So France is very good, it's 15. USA, somewhere like a top 3rd. Korea, China, not good. Okay, so these are the people looking at. So what do measures look like? We looked at depression, anxiety, and stress. As an example, depression items are something like this: inability to become enthusiastic about anything, on the inability to experience anything positive, feeling that you're not worth much as a person. So these are items like that, and you have to decide how much it applies to you. That's the depression items. Anxiety items are in green. I felt terrified, I had dry mouth, I experienced trembling, and those items. Again, You rate how much it applies to you. These are stress items. I found it hard to wind down. I felt that I was rather touchy and so on. Okay, so those are depression, anxiety, and stress. These are psychosis items. You are asked to reflect and decide whether you have had experience like this during the COVID. So have you had the sense that some personal force around you, although you couldn't see anyone, seeing things that other people cannot see? Also, your thoughts are so strong that you could hear them. So these are hallucinatory items. They're delusion items, holding beliefs that other people would find unusual or bizarre, feeling that you're not in control of your thoughts, someone else is controlling your thoughts, and feeling that parts of your body are changing. So these are delusional items. So those are prodromal questionnaire. Going to social disconnection and so on. The quantitative measure was social network index. This is really about how many people you see or talk to on a regular basis, let's say 2-week window. So family, friends, workmates, neighbors, and so on, clubs, churches. So one important measure is total number of people with whom you have regular contact, for example, at least once every 2 weeks. Okay. So you can probably count it in your head. Second is interesting, it's so-called network diversity. It's number of your high contact roles in which you have regular contact. So for example, my roles are, for example, I'm a parent, I'm a friend, I'm a teacher, I'm a colleague, and so on. So I have maybe 5, I'm a neighbor, I have 5 or 6 roles. And with those roles, how many, within those, how many of those roles do I have regular contact with a person in that group? So they're measuring slightly different things. That's more objective measure, okay? You don't have to sort of disclose how you feel about them, it's just numbers. Now, loneliness is really about feeling how you feel about this. So it's about feeling that you lack companionship, how often you feel left out, how often you feel isolated from others. So there's a whole list of these you have to rate. So that's loneliness. So let me show you the results. So depression, how did the 4 countries fare? Well, they were all elevated in depression. These are clinical levels of depression. If you look at the white line, that's sort of a level of mild depression. Hong Kong fares pretty badly. A lot of people are depressed. South Korea also. Remember, South Korea and Hong Kong hardly had any death, very low infection rates. Okay. Korea didn't even go into lockdown. France went into strictest lockdown, depression much lower. US low as well, but there's some people peaking there. The next one is anxiety. Again, Hong Kong and South Korea doing much worse, and France and US are doing actually quite well. Next is stress levels. All 4 countries, obviously, they exacerbate stress levels, but again, Hong Kong's doing pretty badly, and US is doing badly here too. Now, next here is number of days that people felt worried, anxious, or stressed. Here it goes, it's sort of parallel to stress thing. Hong Kong and US, people are saying they're worried, anxious, and stressed. Like 12, almost half here in Hong Kong, half the month out of 30 days. So that's a lot. Now, when you looked at this, when we looked at social network size, that's the objective measure of social connection. France, they have the greatest number of social networks, so a lot of contacts. US, Korea about the same, Hong Kong the least. So the French are well connected, they know a lot of people and so on. How about loneliness? It goes sort of the other way. French are the least lonely, Hong Kong the most lonely. So these are some sort of first sort of level data. When we looked at the psychosis risk, remember psychosis is not that common, it's 1% of the population. We looked at delusions and hallucinations. Delusions are strongly held, highly personal belief that's not endorsed by your own culture, but is maintained with conviction despite all evidence to the contrary. So these can be persecutory or grandiose illusions, for example. Hallucinations are false sensory perception. Sorry, it keeps going back and forth. that has compelling sense of being real despite the absence of anything being out there. External stimulus can be auditory, visual, olfactory, tactile, it can be all senses. I have to say though, hearing voices or feeling the presence of a being is very common in the general population. It's, I would say most people actually have it at some point in their lives, especially after losing someone. So hearing voices, the felt presence, if you have those experiences, it doesn't mean you have risk for psychosis. It's quite common. What can trigger these hallucinations? One is, as I said before, social and physical isolation can trigger it. For example, solitary confinement and sensory deprivation. Right. So these are a lot to look at really in a piecemeal manner. So what we did was we actually created composite psychological distress variable made of major components that we measured. And so each variable for each participant was transformed into standardized scores. And we looked at 4 countries. So up is worse and down is better in this one. So when you look at it, Hong Kong really sticks out. They're doing so much worse than any other countries. And France is doing better, US next, and South Korea hovering around here as well. So what's interesting is psychical distress was not directly related to the infection or death rates or even social distancing measures. For example, Hong Kong was doing really badly. So what was going on with Hong Kong? They had very low infection and death rates. People were living sort of normally, well, for most part, going to work and so on. When we looked at their data here closely, what you find here is that they are suffering. So days, this is a graph, days in the past months where they said mental health was not good is pretty high. They're on average 10 days out of 30 days, they're saying they're not feeling good. And they're about half of the months, I'm sorry, it keeps going. Half of the months, they're worried, anxious. They had hugely elevated levels of loneliness. And if you look at this one, this is percent of people who have, who met the criteria for depression, anxiety, and stress here. So any colored part is you're at risk, with a darker being worse, very extremely severe. As you can see, this is 50% mark. Depression is already like a majority of Hong Kong respondents are meeting criteria for depression, almost 50 for anxiety, stress is only 25% are feeling regular levels of stress. Now, this is a really important part. 22.5% met the psychosis risk criteria, which is rather big. Okay, large number. So what was going on in Hong Kong? Hong Kong was a particularly interesting case here because since 2019, there had been mass anti-government protests, widespread unrest, demonstrations, government sort of, they hit back, arrested people and so on. That was going on before COVID hit. So a study conducted in late 2019, just before this all started, they already had high rates of mental illness in Hong Kong. For example, 12.8% of the population had PTSD. Depression was over 11%. And it was especially exaggerating the younger cohort and those who showed high support for the pro-democracy movement. So we think that the worst outcome Hong Kong has something to do with the fact it was layered on top of already ongoing social unrest, where were people living on really fearful conditions. Now, South Korea, which is very close to the same region of Far East next to China, and really it had the first spike here. When you look at this graph here, it was going up here early March and February here. The first case was Korean citizen returning from Wuhan, and that person brought it to Korea, to a localized city. And there was exponential growth of confirmed COVID-19 cases in the first 2 months. However, they were able to successfully control the spread of COVID, mostly through widespread testing and very fast tracking of infected cases and novel test settings, and very, very high compliance of the general public. So by locking down certain cities, they were able to go about pretty much normally. However, all the schools and a lot of businesses went remote. However, there was no social unrest, so that would be good contrast to Hong Kong here. So this is case of South Korea. Even though there was no social unrest, it was there was infection rate was low. There was very high level of depression. 36.8% of the population scored above mild depression category, and same with stress and anxiety, very high percent, and 12.8% met criteria for psychosis. So they're not doing as well as you think. So when you compare Hong Kong and South Korea, of course, Hong Kong did much worse than South Korea in terms of days of mental health problems, levels of depression, anxiety, stress, and psychosis risk. However, note that South Korean citizens still had significant deterioration in mental health despite successful mitigation of COVID without any political unrest or civil unrest. So it is something else. So political and social unrest is playing a role, but something else as well. Let's look at the family in South Korea. Okay, so when we looked at risk factors for mental health during COVID, the risk factors that popped up were younger age, young people suffering more, being female, and importantly, singles living with family had the highest risk. They were really suffering, not the singles living alone, who we thought would suffer more because they were alone, right? Isolated. But singles living alone were doing as well as married people, so who had lowest risk. So this is what we want to begin to sort of talk about families. We expect families to confer protection against mental illness because they reduce loneliness and they offer support and so on. But often you remember families can also increase the risk for mental illness. So family can be source of both stress, distress, and support. So it depends on what kind of family. And for those whose families are really risk factors, living alone is obviously protective. So it's really about importance of good relationship rather than family units per se, quality of relationships rather than quantity. Okay. Now, this is important here. The singles who are living with family in South Korea are mostly students. They were late adolescents and early adults. So these were late teens, early 20s, and these were all college students or high school students. They're doing things, they're going to school remotely. They had the worst mental health profile during COVID. And therefore, I think we really need for intervention now to reduce self-harm, including suicide attempts in this population. When you look at loneliness across the 4 countries here, US, South Korea, France, and Hong Kong, when you look at the living situation, it makes sense here. So Hong Kong had the highest percent of people living with their families, but had the worst mental health outcome and highest loneliness scores. So here in the case of Hong Kong, even though they had other people around, there are sort of these people are acting as source of stress and distress rather than source of support. Whereas in France here, being together with people was reducing their loneliness scores and improving mental health or protecting against mental illness. France had the highest percent of couples living together, best mental health outcome and lowest loneliness, even though they went into a very strict lockdown. And the US and South Korea are somewhere about the same. All right, so let's look at France and what they're doing. In France, we're able to collect diary entries during COVID lockdown. We also, it's the only country we're able to actually track the same people 4 times during the lockdown period. So we were able to test them and collect their narratives as they went into lockdown, middle of lockdown, end of lockdown, and after lockdown. So you could trace those. When we looked at stress, depression, anxiety scores of French people going under lockdown, this is just as they're going in. What you see is that over time, at first, it's like it goes up, even though they didn't go up as much as others. Then it does begin to taper off here. So at 4, they've come down significantly. That's the depression, anxiety, and stress. In terms of psychosis, you see the same thing at the beginning. Negative symptoms are sort of symptoms that tend with sort of inability to enjoy other people's company. And so that stays about the same. But unusual thought content, which is delusion, perceptual abnormalities as hallucination, they're way up at the beginning. And they begin to come down quite rapidly, actually, as they get used to new situations. So it tells us that it's really important to use longitudinal design and follow the same people to see what's going on. So this is, you can see how they are coping. And when we ask people what's going on in these different time points, as they settled in with their families, even without families, they were having greater number of contacts. So they were talking more, they were cooking together, they were eating together all the time. They were, even if they weren't with their families, they were talking more frequently via phone, text, FaceTime, and so on. So they were actually increasing frequency of contact. Now, we looked at also respondents who wrote narratives. They were asked to write about 10 lines a day about what's just about their life. And what we found was that participants with increased risk for psychosis produced fewer narratives and they had more negative emotional words. And these were done with automated text analysis with programs. So so we didn't bias anything. It just turned out that you can actually predict who has risk for psychosis from the words they produce. So just to summarize those 4 things, across all 4 countries, greater COVID concern, loneliness predict worse psychological outcome. That's something common. So those loneliness and COVID concern are important for all 4 countries that predict a worse outcome. But after that, interesting, in USA, Korea, and France, younger people fared a lot worse than older people. In Hong Kong, age made no difference. They all suffered. Women suffered more, especially in Korea. And in the case of singles versus couples, basically in the US, being unemployed and being single predicts much more worse outcome. But it's a special case because in Korea, France, and Hong Kong, if you're unemployed, it wasn't so detrimental to your financial health in a way because the state would take over. In France, you got paid the same amount of money, whether during lockdown, when you couldn't work. So people didn't suffer financially. In Korea too, there was loss of income, but it wasn't drastic. In US, there's certainly less protection. Now, in the case of Korea, women fared so much worse than any other countries, especially young women living with family members. So that's important to remember, young women is really at risk. And by the end of the summer, infection and death rates were rising rapidly again. So by June, things were getting better, but again, things got worse. And especially in America, during the summer, that it really started going through months of very severe social upheaval as well. So we then looked at what's going on in the US. So at first survey, we're here, next one, as things are going back again. So second phase, we have worsening pandemic, really worsening social political climate. And we began to collect race, ethnicity information, and trauma at this point. So what was going on in the summer last year? Lots of things going on. By late June, about 40% of adults reported struggling with mental health or substance use. So things are going on. There's a lot of things going on. There's on one hand, a lot of people denying COVID is even there. A lot of anti-maskers, anti-regulation protests, as you can see here, with people with guns, with no mask. And there's also Black Lives Matter protests last year. You can see here they're all wearing masks, but this is actually Black Lives Matter protest. So you have anti-mask versus, in a way, masking and social distancing groups. And plus there are lots of other conflicts going on. So we looked at race and ethnicity here because ethnic racial disparities in all health outcomes have been well documented already. And minority communities were disproportionately affected by COVID, especially Hispanic communities. And we expected Hispanic, Latinx, and African-American participants to report greater distress than white participants. So here is a busy graph, sorry, we don't have to dwell on it. So that's depression, anxiety, stress, and psychosis. I marked the normal range in black. Anything to the right of black bars, they're doing worse than normal, the usual range. So when you look at it, it's kind of hard to see visually, but this is what we found. Hispanic population fared much worse than white or African-American population in depression. Same thing with anxiety, stress, and psychosis. They were suffering much more than any other groups. What about social isolation, loneliness, and trauma? Two left panels, social network index, the high contact roles, the network diversity, and the second one is number of people in your group. So, and third is loneliness and the right traumatic events. Again, Hispanic group in green are doing much worse. They had reduced social network and greater loneliness than Black and white groups. And Hispanic groups reported significantly increased number of traumatic events, and Black and white groups with no significant difference between Black and white groups in traumatic events they encountered. Okay, so that's the case, and we're seeing really ethnic disparities and mental health outcome during the mid part of the COVID pandemic. What we also did was we started to collect narratives from American participants as well, because we wanted to really get into what they were feeling in their own words. This is a quote from a doctor from Chicago. "We have all become witnesses to COVID-19 pandemic. History will judge us by what kind of testimony we present." So here are some testimonies for you. This is a young man. He said, "We live in a working class neighborhood in the Bronx, where a main street full of life with barbershops and grocery stores and laundromats. It was a livelish until COVID hit. My mother-in-law knew 8 people who died in her building, the building my partner lived in his entire life until he moved out. Then COVID hit and hit hard. The streets were empty, although they eventually blocked off the main street for city streets so people had more space to walk and play. Seeing kids on Main Street was a mind boggle. People are scared, people are broke. My district has 32% unemployment rate, 4 times the national average. Our borrower is hurting." So that's his testimony. This is a 27-year-old woman. "It's stressful living in Austin. I get irritated all what the white people living about their lives like nothing is happening, and Black people and us are dying the most from COVID here. I expected better since it's a liberal city, but I should have known they don't truly care about us. I just keep to myself as much as possible to be safe. COVID has affected terribly. Mentally, I'm constantly on edge or dissociated. I miss my family." You can just like detect the loneliness and isolation right there. Young woman, oops, sorry. "I was working in a national park this summer where I had to limit the amount of people who entered because of COVID. I was verbally abused daily by people who did not believe that COVID was real, and I was restricting their freedoms. It was extremely exhausting for me too, because I had already lost a family member to COVID. 22-year-old woman, seeing how many people don't take the necessary precautions against COVID makes me sad, angry, distressed, and pain. I've somehow lost hope in people. I tried to regain this hope for me, but seeing the world shifting into something so distant has made me question my own being and what the future holds for me." So again, very sad here. An older woman here. 40-year-old woman, "I've lost all my safe zones. I'm trapped in the place in which I live, which is a place of extreme emotional, mental, and financial abuse. I have also lost my main source of interacting with people. People don't attack me emotionally or otherwise on a constant basis. My physical pain has increased tenfold, being indoors most of the time due to stay-home orders, no or less income, unreliable transportation." So these are some of the stories we heard from COVID narratives. So to summarize what we found in this phase, we found a significant deterioration in mental health and psychological well-being across different countries. And psychological outcome wasn't actually related to how severe COVID infection rate or death rate was, or the public health restrictions. It was about how you coped with it. Loneliness predicted poor mental health even after controlling for demographic variables and COVID concern. And here we have to ask, well, what causes loneliness? We can actually get into discussion of that afterwards. Hong Kong had worse outcome than any other regions. They had other social factors going in there. The French case shows that the power of protective and close and positive social relationship on your mental health is really important, as you know. Families can be, but however, families can be also destructive, as you can see in the Korean case, especially young women. So it's a double-edged sword. And lastly, we find significantly worse outcome for Hispanic population in the US. Oops. So I would like to end with some warning signs here. I think we're on high alert for adolescents. They've had drastically reduced social interaction for a year and a half. They had non-optimal very poor, impoverished academic and learning environment. They may have been exposed to COVID in themselves with their families or friends. They may have lost loved ones COVID, and they may be experiencing increased financial insecurity due to somebody losing job in their family as well. Some will start college this fall. Some will come to Vanderbilt. This will be a major stressful life event. We will collect mental health data on all incoming college students, if possible, this fall. We'll watch out for anxiety, depression, psychosis risk, and so on. And we would like to recommend enhancing well-being and resilience by reducing loneliness, by building friendships, connecting to family, friends, alumni, and so on. Building up physical health, building up coping skills. So what can we do actually to prepare for next pandemic? This is where I think your ideas would be really helpful. I have some things here, but I would like to really hear from you. I think we need to make more interpersonal investment before next pandemic, or in any case, with or without pandemic. We need to build and maintain relationships of all kinds, not just family, not just intense relationship, but all relationships. We need to invest in community, our communities around here. We can volunteer. There's a great health benefits of actually altruism. You can join or start a group and so on. So interpersonal investment, I think, is important. Second is investing in your own body, because healthy body and brain is basically mental health. Exercise, and I think it's important, knowing how to exercise without any equipment, because some of us didn't have access to any of that. So walking, running, hiking, dancing, singing actually is an exercise, gardening and those things. Learning how to exercise without these machines, better sleep, and making sure the annual checkup so that you're up to date on everything. Oh, sorry. I don't know why it keeps, sorry about that. Third thing is investing in your mind, so investing in yourself. Therapy and counseling, or at least knowing how to access it if needed. So knowing who to contact, where to go is really helpful as well. Teletherapy has really blossomed during COVID because we couldn't see people in person. And it's actually pretty good, individual as groups. There are even apps now, but apps are not as good as actual teletherapy because you're contacting with a real therapist there. We also need to, oh, sorry, gosh, I need to go. Okay, so we need to reward ourselves experientially, not materialistically, but the travel, creative pursuits, writing, knitting, cooking, anything, acquiring a new skill, all of those things, but that's really investing in yourself. So here I'd like to end by asking for your ideas and suggestions, which I would like to test out. So here I'd like to thank all of you for being here. It's been great privilege. And I'd like to thank students during the pandemic, conducted all these studies. They're outside Wilson. This is last lab meeting we had in late April, where we were able to take our masks off and take a picture. And also all the collaborators in different countries, Professor Anne Giersch in France, and Alena Gistic, who actually was here in Vanderbilt. She's from Croatia. And Felsenheimer from Germany, then other colleagues in Michigan and Vanderbilt University. Thank you very much, and I look forward to your suggestions.
Thank you so much, Professor Park. That was very interesting and obviously so important to learn about right now. We have time for a few questions. One question that we received during your presentation was, did you find that there were differences in reluctance to talk about mental health among the 4 countries?
This we couldn't really test out because this was online survey study. So we sent survey to massive numbers of people. And I guess we can compute the number of surveys we sent out and how many people responded, right? So, but anecdotally though, we've done survey studies before and we hardly ever get any subjects. And during the pandemic, we actually got people. And I think it's because we were locked up and they needed something to do. So at least at the beginning. So yeah, but I think in Hong Kong, there is actually anecdotally, again, Hong Kong, we had to wrap up our study quite early. We wanted to actually follow up. We couldn't because of political situation, and it wasn't really, we weren't allowed to collect data anymore. So there's that. So things, yes, but that's a really good question. And whether there's a sex difference between people respond because more women than men in all of these surveys.
Could you speak a little bit more to what you were referencing about loneliness, about what causes loneliness?
Well, lonely, when you think about it, is that it's really difference between what you expect, what you want versus what you get. So if you're expecting you will have, I don't know, let's say 10 very intense friends, intense friendships, and you see them every day, that's your expectation, but you only have contact with one. There's a huge gap in what you expect and want and what you have now. And that gap seems to cause distress. So it's a combination of what sort of your mental kind of representation of what you want, the ideal picture versus what you have currently. So you can approach loneliness from either hand, either kind of recalibrating your expectation or increasing number of people who you have close relationship with. But it has really a lot to do with not so much the number of friends or frequency of contact, is how emotionally connected you are. And that's hard to quantify, but we subjectively, we know what that is. Is that, so even with family, we might have a large family, and you might feel actually very lonely within family because you couldn't talk to anyone. And secondly, so that's that. And secondly, loneliness is very common, especially older people and younger people. So, and it's as Dr. Murthy says, it's an epidemic of loneliness. We're pretty much disconnected. So disconnection, being a minority in a majority population, that causes loneliness also. So there's a lot of things going on. It's a fascinating research area. And the people who do most of this research actually are based in Chicago. So yeah, this Stephanie Cassioppo at University of Chicago, she's been looking at loneliness, and her late husband, Dr. Cassioppo, they've been looking at, they sort of came up with a whole concept of how to measure loneliness. So yeah, but you can be socially isolated and still not feel lonely. So I think what I'm saying is that there's lots of different ways to intervene, even if you're alone.
Well, having those tips from you is also helpful, thinking about if we're ever in this situation again, how we can be better prepared next time. Mm-hmm. So thank you very much.
But I think you guys probably have a lot of ideas too. So what I'd love to do is if you have ideas, if you could email me with your ideas of what worked for you during the COVID, and we could see if we can implement that into making to sort of social kind of vaccine program for undergraduate students at Vanderbilt.
Absolutely. Well, thank you so much, Professor Park. We really appreciate your time and you sharing all of your research with us. We'd also like to thank everyone for attending today's lecture. We hope to see you again at future Vanderbilt events. Please remember to complete the quick survey that we posted in the chat box. And thank you again, and we hope that you all have a great day.
Thank you very much. Thank you. Bye.